once you know that it's worldwide, all spread around, and that given its prevalence, everyone should be aware. Unfortunately, everyone is not aware, still not aware. I think there is better knowledge, at least better awareness among health professionals, but there's still a lot of stigma, there's still a lot of guilt, there's still a lot of unknown. There are still a lot of professionals who have been trained without its knowledge, and therefore, there's no continuous education, then they don't have the knowledge. We're trying to teach the younger generations that this is a major challenge. We're trying to spread the word, and so are actually some users, families, associations, things like that. We need first-line primary caregivers, first-line health professionals, mental health professionals to be aware, and probably we need to have them be able to use very simple tools, like one of the tools that was invented in the UK, the Edinburgh Postnatal Depression Scale. But even that is a 10 question self-questionnaire that's filled very easily in a waiting room. That's how it's validated, actually. But even 2 or 3 questions in that questionnaire, there have been tests made with only 2 or 3 questions. Among those 10 that are enough, if unfortunately the response is positive from the woman to get you on alert that the risk of developing a depression is high. So we probably need everyone to have these tools, to know how to use them, to not be afraid to use them. But also one of the current challenges is that given the stigma on mental health and given the unawareness, there needs to be training of how to address this issue. If everyone is considered as potentially, unfortunately, more or less at risk of postnatal depression after a pregnancy, then it will be destigmatized. If we have a general screening, if we have overall knowledge that this is like taking your blood pressure or asking very simple simple general health questions, and how do you feel since you've given birth, without making women feel guilty, without supposing that they should be feeling great. It's not, oh, you're feeling great, okay. Then we will be able to move forward into recognizing the fact that this is, a widespread illness. Of course, there are populations that are more at risk than others. So if you can't do it with everyone, then you should focus on populations who have at least one other risk factor. But essentially, everyone should be screened. 16%, that's just everyone should be screened. What other medical illness that's over 10% is not being systematically screened for? So that is really the number one message. Now, I know that one of the reasons why, and this is sort of anticipating on the next question, but one of the reasons why colleagues or even mental health professionals or just health professionals or even the layperson who is, your good friend or so on and knows about these things doesn't ask these questions is because they, apart from the stigma, they feel that there is no help available, that there is no cure, that there is no treatment. And so let's sort of pretend it doesn't exist that way. Maybe it'll go away. But there are treatments. They're not perfect for the moment. That's what we've been actually talking about, trying to get new treatments. But even with the old treatments being acknowledged, being supported, even having some non-pharmacotherapy treatments, there are for at least light or moderate, not severe depression, obviously, but for some forms of depression, those work, they exist, they're important. It's also important to have family and social support because that really does help. It is a protective factor. Even if it doesn't stop you from being depressed, it helps you get better more quickly. So we really need to screen and to recognize and to acknowledge and to have a correct diagnosis. And if I have one more clinical advice to give about diagnosis, is depression is not the blues. The baby blues, which is sometimes either confused or more or less unconsciously, let's hope it's the blues and I won't look if it actually isn't the blues, but depression. There are major differences between the blues and depression, but the one first difference is that the blues do not last. They cannot last. So whatever symptom there is, if you're not sure that it's depression, or if you hope it's not depression, if it lasts, even if it's not a major life-threatening symptom, if it lasts more than a few days, and definitely if it lasts more than 8 to 10 days, it is not the blues. It cannot be the blues. So please, let's not sort of dismiss and push away something that's so important for the life of women, because it can last many weeks and many months and really make their life and make their life miserable. And there is a major risk, which is suicide. So we should not let this pass by. And it is also something very important from an infant and child perspective, because it has an impact on the child and on the rest of the family, actually, especially if there are other children, etc. So we really, it's a major challenge, but it is also something to look positively at, in the sense that we can really make a difference. We can change the way we address this issue in the decades to come. And so I hope we can do better for our patients.